Welcome to today's presentation. We're going to be looking at a second part of pre-anaesthetic screening, and today looking at why would we include a complete blood count as part of a pre-anaesthetic screen. So what we're going to cover today is a case example, look at the value of doing a PCV and TP, but then when we compare to just the PCV and TP, what extra will a complete blood count bring to a pre-anaesthetic screen? So this is Missy, a 6-year-old female spayed Cocker Spaniel who was presented to me at a referral clinic because she was bleeding from her mouth. Her history was that she'd seen her primary care veterinarian a couple of weeks before for just a routine checkup and vaccination, and they found as part of that wellness check that she had moderately severe dental disease. So they planned for her to come back in about 10 days' time to have a dental done. As part of that procedure, she had a pre-anaesthetic screen that consisted of a PCV and TP. You can see the PCV and TP were normal at 45 and 72, and a Chem 10 screen, and all of those parameters were within reference intervals. So she had a dental cleaning and she needed 2 or 3 extractions done. The vet, who was very experienced, just noticed that there was some blood oozing from the extraction sites, and despite their best attempts at hemostasis, it just wouldn't stop. So she was referred for further evaluation. So at the time I saw her, she was still somewhat sedated from her anaesthetic. Her temperature was a little bit below the reference interval, but that's not surprising given that she just had an anaesthetic. Her heart rate, pulse rate, respiratory rate were normal. Her mucous membranes were on the pale side, pale pink side. Refill was okay. And when you looked in her mouth, you could see it wasn't blood gushing out of her mouth by any means, but there was active bleeding from the extraction sites. So at this stage, what are our problems? Well, clearly the problem is that she's bleeding in her oral cavity. That suggests that we have, that could be from a local issue with the dentistry, but experienced vet doing a good job and in multiple sites tells us it's not likely just something from the extractions itself, that we're more concerned about a bleeding disorder. That could be a problem in the primary arm of the coagulation system, so platelets or vessel wall, things like von Willebrand disease, less likely in a dog that's 6 years old and was spayed uneventfully. Or it could be a coagulopathy, so something affecting the coagulation cascade. So plans at this stage were to do a complete blood count and also to do some coagulation testing. And we just put her on some fluids because, she was bleeding. If we look at why we do pre-anaesthetic screening, excuse me, this is a paper from back in 2018 from the Canadian Veterinary Journal. And what they talked about in this paper is the aim of pre-anaesthetic screening is to reduce the risk and increase the quality of care by identifying pre-existing medical conditions and potential anaesthetic difficulties. So how is a CBC going to contribute to that? Well, we'll talk about that soon. So doing a PCV-TP is a solid start for looking at, the hematologic side of things. It's telling us, do we have an adequate red cell mass or not? Having the total protein is a useful parameter for us. If we do have a patient that's anemic, for example, it may give us a little bit more clue as to the cause. So if you're anemic and hypoproteinemic, I'd worry more about hemorrhage as a cause. If you're anemic and the plasma is pink or yellow, maybe we're more likely dealing with hemolysis. But the amount of information truly is somewhat limited with that. So we're missing more detailed information about red cells. We're not really getting any significant information about the white cells, nor are we getting any significant information about platelets. So if we look at the red cells, the PCV can tell us if a patient's anemic or not, but it's not telling us if that anemia is regenerative or not. And that really makes a difference as to the cause and how we're going to um, undertake a diagnostic investigation on a patient. So if it's regenerative, we're looking at hemorrhage or hemolysis. If it's not regenerative, we're looking at bone marrow disease with that. And as I say, it's going to make a difference as to how we investigate that patient further. We sometimes see reticulocytosis without anemia, and there are a couple of groups of causes for that. Sometimes it's physiologic. A patient that's anxious when its blood's collected can get release of catecholamines, and that's going to cause splenic contraction. The reticulocytes tend to hang out in the spleen while they're maturing, so if we get that splenic contraction, more can come out into circulation. Things I look for with that are if a patient's had haematology before, is the hematocrit stable, and if they consistently had some degree of reticulocytosis with that. Whereas in other cases, that reticulocytosis without anemia can be an early indicator of underlying hemorrhage or hemolysis, but the patient is not yet anemic, but it can be an earlier marker of disease. So if you say looking at the results in VetConnect Plus with that, if you've got a dog who's consistently run at a hematocrit of about, say, 45 or 46, and hasn't had retics before, and today its hematocrit is 37 and there are reticulocytes there, I'm going to be more concerned about the possibility of underlying hemorrhage or hemolysis. We're not going to cover how we're going to investigate those today. That's a little bit beyond the scope of this presentation. We sometimes can see erythrocytosis, so an increased red cell mass. That can be relative because of dehydration. If that's the case, it gives us information that we probably need to have that patient on fluids. Or it can be absolute. That can be because of increased erythropoietin levels, which can be physiologically appropriate with hypoxemia, so heart or lung disease. It can be physiologically inappropriate with things like renal masses producing erythropoietin, or it can be primary, so no increase in erythropoietin, but a bone marrow malignancy that's causing increased production of red cells. We get the indices when we're looking at if we do a CBC. So are they microcytic or macrocytic? Is there hypochromasia? So if we've got a macrocytic hypochromic anemia, more likely regenerative. Things like iron deficiency, we might see microcytosis and hypochromasia. An increased red cell distribution width may suggest that we could have a regenerative response. Retics are going to be more accurate with that, but still some useful information with those indices. The reticulocyte hemoglobin, which you get if you're running your CBC in a ProCyte DX, or if you're running the CBC through the lab, is, as it says, telling us about hemoglobin levels in reticulocytes. And this is a nice marker of iron availability for erythropoiesis, because we're looking at cells that have only been produced in the last few days and are only in circulation for a few days. So they're giving us a much more acute indication of iron availability. Serum iron levels and iron profiles are difficult to interpret. And because of the average lifespan of a red blood cell being, 100 days or so in a dog and 70 to 80 days in a cat, it takes a while for the MCV to drop in that setting because it's looking at the average size of the red blood cells. So reticulocyte hemoglobin is giving us a much more acute indicator of that iron availability. The reasons it can be low: through iron deficiency with blood loss, not that common, but blood loss through the gut or through the urinary tract. It can be a reflector of inflammation. With inflammation, we get the release of a substance called hepcidin, acute phase protein, that basically traps iron in the cells where it's stored. So enterocytes, macrophages, and hepatocytes, so it can't get used for red blood cell production. And less common causes are things like portosystemic shunts or some breed-related things. So, for example, Japanese Akitas that are naturally microcytic will have a low reticulocyte hemoglobin as well. If we look at the white blood cells, with the PCV-TP, we're not getting any information at all about the white cells. So things like a neutrophilia could be a reflector of a stress leukogram or inflammation. Neutropenia most commonly is going to reflect consumption of white cells because of an inflammatory or infectious process. It would also reflect immune-mediated destruction or bone marrow disease reducing production. If we see a left shift, it doesn't matter what the white cell count is or what the neutrophil count is. If we have a left shift, that's telling us we have an inflammatory process going on, and we may know what that is if it's an unwell patient having an anaesthetic, but if it's a well patient, it may prompt the need to do further investigation. A lymphocytosis can be because of antigenic stimulation, a catecholamine effect, things like hypoadrenocorticism in dogs, or could reflect even a leukemia, and that's important to know before an anaesthetic. Whereas a lymphopenia may simply be an indicator of a stress leukogram, but a stress leukogram hasn't just come because the dog or cat got anxious in the waiting room. They take at least 4 to 6 hours to develop, so maybe a reflector of an underlying disease process. If we look at platelets, one of the more common things we're going to see on a CBC is thrombocytopenia as an artifact because of platelet clumping. So, having a look at a blood film or looking at the dot plots can give us an idea if there are clumps there or not. And looking down at the feathered edge of a blood film can help us with that. And you can see on this image here some platelet clumps there. Whereas if thrombocytopenia is pathologic, that can be a reflector of bone marrow disease reducing production. It can be consumption because of hemorrhage or vasculitis or disseminated intravascular coagulation. It can be immune-mediated thrombocytopenia with destruction of platelets, and occasionally we see it as a breed-related phenomenon. So, for example, Cavalier King Charles Spaniels or some of their crosses with a macrothrombocytopenia. So they lack a substance in their bone marrow called beta-tubulin, which helps the megakaryocytes divide. So in that setting, they'll have a low platelet count, but the platelets there are large. So you might see a high MPV or mean platelet volume and a normal platelet crit on the CBC. So that's not necessarily pathologic. But, without having the CBC, we're not going to know what the platelets are. And that, if they are thrombocytopenic, that puts the patient at more risk under that anaesthetic procedure or with a surgery. Thrombocytosis can be a reflector of hemorrhage. So, for example, gastrointestinal hemorrhage. Platelets can go up with inflammation. Platelets can go up with glucocorticoids, and occasionally may be a reflector of an underlying malignancy. So if we come back to our little friend Missy, who we were talking about at the beginning of the presentation, her hematocrit was marginal. It's sort of on the border of being anemic or not. Not really surprising. Her PCV was normal before the procedure, but she's been bleeding, she's been on fluids, so not a surprise that the hematocrit has dropped. Her reticulocyte count would suggest a non-regenerative anemia, but given she's only been bleeding today, we wouldn't expect a significant reticulocyte response. The white cells were normal and the differential was unremarkable. The automated platelet count was 30, so significantly reduced with a normal of over 200 by 10 to the 9 per litre. On a blood film review, there were no clumps and there were only 2 to 3 platelets per high power field, confirming that she had thrombocytopenia. At this level of thrombocytopenia, a patient is not necessarily going to be spontaneously bleeding, but can certainly bleed with an insult. And so this is why Missy was having the hemorrhage associated with her dentistry. The PT and APTT were within reference intervals. What we did with Missy is we did, given she was a 6-year-old dog, if she's got immune-mediated thrombocytopenia, there's that chance of an underlying disease. So we did thoracic radiographs, an abdominal ultrasound, and a urinalysis, avoided urinalysis, not a cysto, looking for underlying disease, and none was apparent. So we elected to manage her as an immune-mediated thrombocytopenia patient with immunosuppressive doses of prednisone and some azathioprine. And she staged a pretty unremarkable recovery with this. Her platelets had started to normalise within a couple of days. One option may have been to give her some vincristine as well, but in this situation, her owners were reluctant to do that. So we went with the prednisone, and overall she had a very uneventful recovery. So in review, I think, we do pre-anaesthetic screening to try and make sure we can't see any underlying diseases or risks that might affect the anaesthetic. When we look at a CBC in a pre-anaesthetic screen, it's giving us an extra layer of information over just doing a PCV and TP. So with the red cells with anemias or reticulocytosis without anemia, for white cells determining underlying inflammatory disease or stress response, or potentially even occasionally things like a leukemia. And for platelets specifically, we're looking for things like thrombocytopenia, which can have an adverse effect on a surgical procedure. So I hope this has been helpful for you. If you have any questions, please don't hesitate to reach out, and hopefully we'll see you again soon on another webinar in our continuing education series. Thanks very much.